From the RSNA, I'm Dr. Jana Ivanidze, and this is the Radiology Imaging Cancer Podcast. In this episode, we're going to talk about global health approaches to oncologic imaging and radiation oncology. This is my second episode hosting this podcast, and I'm happy to share that our team has grown since the July episode. By the way, if you haven't had a chance to listen to that one, I hope you will. I got to speak with leaders in the field of health disparities in oncologic imaging, Drs. Efren Flores, Joe Osborne, Ashley Prosper, and Randy Miles. Radiology Imaging Cancer has recently appointed a trainee editorial board with rising stars currently pursuing diagnostic radiology, interventional radiology, and radiation oncology residencies across the US and in fact around the globe. Our trainee editorial board members are not only going to be involved in all aspects of the editorial process, they are also going to take an active role in producing this podcast. Radiology plays a key role in oncologic care. However, while we are on the forefront of innovation with advanced imaging methods and AI, improving diagnosis and treatment, there are large disparities with regards to access to diagnostic and interventional radiology and radiation oncology for cancer patients across the globe. Lack of training opportunities results in exceedingly low numbers of radiologists and radiation oncologists in low and middle-income countries. And lack of resources also translates to limited access, particularly to advanced imaging modalities and interventional radiology procedures. It is important for us as cancer imagers to take a proactive role in improving access and thereby clinical outcomes for patients worldwide. On this episode, I'm honored to introduce to you an outstanding group of radiologists and radiation oncologists who have gone above and beyond in this regard. This will be a two-part episode. In part one, we will hear from Dr. Maria Gosein, lead author on a study recently published in Radiology Imaging Cancer about MRI-based prostate cancer diagnosis in Trinidad and Tobago. We will also learn about Road2IR, an organization focused on improving IR specialty training in low and middle-income countries, founded by IR Chief Fellow Dr. Fabian Gaupp and Emory neuroradiologist Dr. Frank Minja. Dr. Bhavya Rehani from UCSF will talk to us about her nonprofit organization, Health for the World, that has the goal of improving medical education and scholarship worldwide and increasing healthcare access. I really enjoyed bringing this inspiring group together and hope you will enjoy learning from them. But first, a message from the RSNA. Make plans to join us at RSNA 2020. Virtually connect with colleagues and industry partners. Explore RSNA's first ever digital exhibition floor and AI showcase, and access more than 350 hours of the latest science and education from every subspecialty. All RSNA members get free premium access to RSNA 2020, which includes CME opportunities, on-demand programming, and extended access to meeting content through April 2021. Register now at rsna.org/annual-meeting.
Hi, my name is Mateus Taveira. I'm a third-year radiology resident at AC Camargo Cancer Center in São Paulo, Brazil. I have recently become one of the members in training of the editorial board of Radiology Imaging Cancer. I have here with me today Dr. Maria Gosein, first author of a manuscript published on our August issue titled Biparametric MRI prior to radical radiation therapy for prostate cancer in a Caribbean population, implications for risk group stratification and treatment. Dr. Maria completed her radiology training at the University of the West Indies in Trinidad and her abdominal radiology fellowship at the Vancouver General Hospital in Canada. Afterwards, she was appointed as a lecturer in radiology at the University of the West Indies, and her main research interests are in prostate cancer and radiology education. Thank you for being here with us today.
Thank you so much for having me.
It's our pleasure. So briefly, the manuscript we'll be discussing is a retrospective cohort study analyzing the pragmatic effect of performing biparametric prostate MRI, meaning prostate MRI without contrast. One of the reasons this manuscript sparked my personal interest is because I too come from Latin America and have had most of my training here. Since med school, we become acutely aware of limitations in healthcare access and balancing what we know is gold standard treatment and what is actually available. So, without further ado, to contextualize for our listening, my first question for you is, how does a man over 60 in Trinidad and Tobago get worked up for prostate cancer?
So just for some more context, I'll start with some demographic information. In Trinidad and Tobago, prostate cancer is the most common cause of cancer and cancer-related mortality in our local men. And we have two main ethnic groups, roughly equal in proportion, men of African ancestry and men of East Indian ancestry. And our urology colleagues published data from our largest public hospital showing that prostate cancer was 3 times as common among Afro-Trinidadians compared with Indo-Trinidadians, with Afro-Trinidadians more likely to have high-grade and high-risk disease. So to answer your question, diagnosis is typically made via a standard 12-core systematic transrectal ultrasound-guided biopsy, which is done based on clinical suspicion. And in terms of imaging workup of known prostate cancer, this is guided by their risk group. We have X-ray, CT, and MRI freely available through our public healthcare system. Bone scans and PET scans are typically privately paid for, so that brings about accessibility issues. But there are no prostate cancer-specific PET tracers yet available locally. Multiparametric MRI is available in both private and public institutions, but at the moment utilized mostly for local staging studies. The use of MRI prior to first biopsy with cognitive fusion biopsy is practiced only on a small scale, and software fusion biopsies are not yet available. So we've had some men travel abroad for this. So we looked at what patients' NCCN risk group would have been, incorporating all clinical, biochemical, and histologic parameters prior to MRI and then following MRI. And we saw that there was upward risk group migration in 38% of men following MRI, with substantial shifts affecting all risk groups. And this had management implications and led to changes in clinical target volume for radiotherapy or initiation or prolongation of androgen deprivation therapy, or both, in nearly half our study population. And these shifts that we saw were higher than that seen in published literature, with these published studies that were mainly conducted in white populations. And compared with other races, prior studies have shown a greater incidence of prostate cancer and more aggressive disease in African American and Afro-Caribbean men, with increased risk of progression on active surveillance and grade group upgrading following radical prostatectomy. So at the end of all of this, the question is, should we consider inclusion of MRI prior to definitive external beam radiotherapy for all NCCN risk groups for our patient population? But the answer to that must come from large-scale prospective studies and follow-up of clinical outcomes.
Yes, I agree that we do need prospective studies, larger studies, but let's not overstate the main finding of your study that is pretty impressive. So 49.4% of patients, they had their treatment plan modification based on a single biparametric MRI. I think that's an amazing result. And what would you say are a few caveats or limitations of your study?
Yes, so this is something we certainly must acknowledge. So this was a retrospective study in a single center. And unlike a surgical study where you can correlate your MRI with a prostatectomy specimen, there was no final histologic correlate here, since external beam radiotherapy was the definitive treatment of choice for this cohort rather than surgery. Also, being the sole fellowship-trained prostate imager involved, we just had a single reader for these MRI studies. And, there is a measure of inter-observer variation when reading these kinds of studies. We also have to acknowledge that MRI can result in overestimation of T3 disease. and hence leading to possible overtreatment. So patients must be counseled appropriately on the risks versus benefits of MRI guidance for treatment adaptation with respect to potential treatment toxicity versus the likelihood for improved biochemical control and overall survival. But we hope that this study can be a starting point for larger prospective studies. Essentially, the end goal here is to know, is there a survival benefit from this MRI-based change in radiation therapy management? So ultimately, what would be required is a study of our men in a randomized trial.
I see. And so one of the major importances of this study is investigating this population that's overlooked. And as you have referenced in your study already, Caribbean men have worse survival than white men from North America, and in particular the Afro-Caribbean men. And there is some data addressing that this is often the result of healthcare access. And how do you think your study contributes to addressing this unmet clinical need?
Yes, I have seen those studies where healthcare access is similar, then outcomes are also similar. But we know that here there's likely a combination of factors leading to adverse outcomes, whether it's delayed presentations or environmental factors. But let's look at Trinidad and Tobago, where there's free, equally accessible public health care, but we're seeing different disease in our two major ethnic groups. So you have to think about other factors. You certainly have to think about genetic factors at play. But I agree with you that improved healthcare access overall contributes to improved outcomes. And so our study highlights the severity of prostate cancer in Caribbean men. So this can help with raising awareness of this issue in the international radiology and medical community. And there are migrant Caribbean populations all over the world. So these men can be targeted with early interventions, and perhaps imaging can play a greater role in their management in an aim to improve outcomes. And there definitely needs to be more research and more representation of these men in clinical trials to better understand the biology of disease affecting them.
It's my understanding that this study was done without any pharma industry support. And as a researcher myself from a developing country, I know the difficulties, the troubles we have to do high quality research such as yours. So what would be your suggestion for a researcher from a low or mid resource country that wants to do high quality research, and what are some of the challenges you have faced yourself in doing this study?
So we see our patients presenting differently or progressing differently to the reported literature. And you wonder, what can we do in the imaging world to change this course? But when you have limited resources, research becomes that much more challenging. We don't have electronic medical records in our public sector. We don't have the resources to conduct any large trials. But I would say start small. Start with those audits and quality improvement activities to improve your workflow and make the best use of your resources. You know, without the data, it's difficult to influence public policy. So as challenging as it may be, keep that end goal in mind, that this will ultimately help your patients, and getting your work out there might mean that you can help similar populations. And it's so important to study our populations and other minority populations, so to speak, so that policies can be made that would be inclusive and effective for all. And I really must congratulate the Radiology Imaging Cancer team for this global radiology initiative. And I certainly look forward to seeing more programs like this in the future.
Yeah, well, in the name of all the board, thank you. I must say your answer is very inspiring.
Just, you know, we need to gather more evidence to answer these questions. And well, thank you very much for your kind words. And it was an absolute pleasure speaking with you.
Good evening, guys. My name is Ricky Savjani. I'm a resident at UCLA in radiation oncology. I'm a second year in the program. And today I have the honor and privilege of interviewing Fabian and Frank, who are founders and developers of Road to IR, a very special initiative of teaching interventional radiology in Tanzania. So this story is very near and personal to me because my father was born and raised in Dar es Salaam, Tanzania. He emigrated to the US when he was 17 years old. He went on to become an MRI technologist, and he instilled imaging, both me and my brother, who became an interventional radiologist himself at a very young age. And my father still speaks very, very fondly of Tanzania. And I'm very excited to talk to you today as part of the Radiology Imaging Cancer podcast series on global health initiatives.
So essentially, Road to IR is an interventional radiology training program, and the whole program sort of got started in 2017. So Frank is originally from Tanzania, so he's been going there for many years, and he's been going there at least twice a year and bringing radiology residents along with him. Just to give some context, Tanzania is a country of 60 million people, and they currently have about 60 diagnostic radiologists, so like 1 per 1 million. And their first diagnostic radiology training program only started in 2007. It's like, so I went there with Frank in October 2017 and basically did what's called an interventional radiology readiness assessment. And more importantly, there was already a diagnostic radiology residency program, which had actually grown almost like exponentially since 2007. And, with multiple trainees interested in IR, but no one there to train them. So certainly there were also things that were missing. There was no disposable IR equipment, and there were no techs and nurses trained in IR. But, essentially we felt like a lot of the components that are needed to start an IR service and an IR training program were already there.
We actually were asked by the executive director of Muhimbili National Hospital because he was aware of what interventional radiology could do. And so he wanted to know, is there any way that we could actually do interventional radiology at Muhimbili National Hospital? And I'm not an interventional radiologist myself. I'm actually a neuroradiologist. And so I knew Fabian had an interest in interventional radiology and happened to have an opening on one of our trips. I wasn't actually very hopeful that we'll be able to get this off the ground, because as many people, you sort of assume they don't have the equipment, they don't have disposable equipment. You basically just assume many of the physical barriers. And I think Fabian's assessment made us realize that actually many of the physical barriers, the physical plant was there. And most importantly, we had trainees who were willing to learn.
Wow, that's really excellent. Were there any technological challenges that you guys had to face, especially in terms of the IR training?
Yeah, I mean, many, obviously, starting with having more availability to a more high-level angio suite. I think that was sort of right now the main technological challenge that we're facing. So other technological challenges, one thing is right now a lot of the teaching happens online. So one thing that we're working on right now is improving the internet accessibility. So far, all of the Zooming, et cetera, happens through like mobile internet. So right now we're installing a high-speed Wi-Fi in the IR facilities there. So actually just last week we purchased five new routers, and they're actually sort of on their way over to Tanzania this week. Someone's going to take them there on a flight this Friday, because especially now with COVID, we rely a lot on online teaching.
Yeah, absolutely. Yeah. I imagine IR is a lot more hands-on training than just diagnostic radiology. So with COVID-19, that's interesting that you guys are getting set up with that. Great.
And I was just mentioned just on that hands-on training. So this is also something that's very unique in our training, is that we send the teaching teams over to Tanzania, right? So many times when people think about bringing a subspecialty to Africa or other under-resourced areas, they think about taking a few great students and bringing them to programs abroad. And we kind of done the inverse. One, because many times it's not possible for trainees to have hands-on training in the United States or Europe or Canada for that matter, just given all the malpractice and other hoops that the students have to go through. So they can come here for an observership and they can watch as many procedures as they want, but obviously, as we know, that is not going to make you into a surgeon. You actually have to practice. So we had started with very basic percutaneous procedures, including like nephrostomies, biliary drainages, abscess drainages, and core biopsies. But some of these really have proven to be life-saving. Many of these patients may have end-stage cancer, especially uterine cancer, that results in like blockage of the ureters. And so literally, they are not dying of that cancer per se, they're dying because of urinary obstruction. And so this really can be a game changer, providing some relief for those patients.
Wonderful, wonderful. And I saw that you guys had gotten a grant from RSNA and others. How has funding enabled you guys to do some of the, either to send people over or to get things moving?
Yeah, I mean, it's huge, obviously. So after that first assessment in 2017, our feeling was basically that we have like a really amazing opportunity to really bring a lot of urgently needed basic healthcare to patients in Tanzania. A lot of these procedures are what we consider absolutely basic, necessary stuff that you can get at any community hospital, even in the US, right? And to imagine that, like a young female in her 30s with metastatic cervical cancer would have to die because of urosepsis is horrible. We have an opportunity here to bring a lot of value to the doctors that are going to be learning IR, but mostly to the patients in Tanzania. So let's say, for instance, you send someone to Tanzania and they put in a drain, but then, the patient has either a complication or needs some sort of follow-up in the following weeks, and they will obviously need someone there to do that. So that's why it wouldn't be enough for us to just send someone every 6 months. So we said, okay, either, we go big or we go home, essentially. Until now, the spring of this year, when we got the RSNA grant, we were actually constantly sort of struggling with financing because we want to send a team there once a month for 2 weeks. So initially, the first 14 trips were really financed mostly through donations. So we started a little fund at Yale where people could donate, and a lot of Yale faculty and family members donated. So that really was instrumental in getting things started. And we got some money from different sources, organizations, including the Doximity grant, which really supported several faculty and trainees for their flights. But essentially what changed now that we have the RSNA grant is that we're in a much better position than we were ever before, because now we can comfortably say, okay, we can pay everyone's flight for a full year. Wow. And then on top of that offers research support money for the trainees in Tanzania, which is also a big deal because they actually pay for their training. So, and they do a lot of research in the context of this new training program.
Wow, that's wonderful. One question that I had, and we faced this question when we went to Nairobi 15 years ago, was that sometimes when you go there and you train students and you train top students, especially when we were doing programming, many of the students who get this training or who get advanced education, they end up leaving their home countries. But how do you guys propose that you keep these interventional radiology trainings going in Tanzania such that it's sustained over time, and how do you see that happening?
That's a great question, and we thought a lot about that. One of the things that we were very fortunate to get through was to get a curriculum approved at the local university. And that is basically intention to be almost similar to a USA fellowship training. So instead of 1 year, it's actually going to be 2 years because we are sending teams every other 2 weeks. And so by being trained in Tanzania, by getting your degree in Tanzania, most likely your certification is within the country. And so while you have the skills to perform, all of the licensure and everything is actually within the country. So that is one way. The fact that they're training in that local environment where they're able to overcome all of the challenges, it actually makes them more uniquely positioned to practice in Tanzania than practicing abroad. Fabian and others in our team have been very instrumental in getting them plugged into major international networks that are very much supporting them all along. They've already been to some of the Society of Interventional Radiology meetings. But the hope is that basically by establishing a degree program in Tanzania, eventually some of these trainees will take over those training responsibilities. And so even if 30% leave, hopefully 2/3 will remain. So it's an evolving question, but again, the demand for IR service is actually skyrocketing as we speak. And fortunately, it's very much recognized, so it's actually highly valued work. So those are other ways in which we're hoping that they'll be enticed to serve the population at home.
Wow, that's wonderful.
Yeah, and I think that the accreditation piece is really important and needs to be highlighted, because Tanzania, for instance, is like extremely strict with these things. So basically, when we first started discussing this with the trainees in Tanzania back in 2017, they made like very clear from the beginning that it's really only going to have value if they actually get a degree from this, because without having a degree that certifies them that they're able to do interventional radiology, they will not be able to get government jobs and, basically practice what they want to do. So that's why we, from the very beginning, we really tried to focus on that. And then it got approved in October of 2019. That's the first accredited IR training program in all of sub-Saharan Africa. And I think it's a big deal for the trainees, and it will certainly, help them sort of in their careers going forward in Tanzania. Actually, one of the trainees in the first class is from Rwanda. So once he has his degree next year, he's planning on going back to Rwanda and then starting a training program there of himself. And so already now it's not just about Tanzania, but it's really about the entire region. In sub-Saharan Africa alone, you have like 1.1 billion people. And of those, while there are no exact numbers, I can say that certainly over 90% don't have access to IR right now. Tanzania, Rwanda, Burundi, Uganda, and many other places, there's not a single interventional radiologist.
Yeah, that's really amazing, as it seems like Road to IR has not only solved the brain drain problem, but maybe created opportunity for people to come in and get some training and then bring it back to Rwanda and other places.
And maybe the last question is, how can folks involved in interventional radiology around the country and around the world, and also trainees, get in touch with you and be involved and be a part of Road to IR?
I'll ping it to Fabian, but we need all the help, and we're very much open to having people join us.
Yeah. We've had medical students and residents from all over North America and medical students from Germany even. So it's really been like an amazing team effort. And at this point, there are 50, 60 people that are in some way or shape have been to Tanzania or involved with the ongoing project or planning on going to Tanzania. But like Frank said, we need all the help we can get. And even right now, while we can't send teams there right now, we're doing a lot of online teaching. So every week we have at least 2 or 3 online teaching sessions. Can be anything from like a journal club to like a board review session. So yes, we need a lot of faculty. We need a lot of technologists and nurses, to go on those trips. I think going forward, it's going to make it a little bit smoother, because we're going to be able to say, okay, all trips are automatically funded, at least for the first year, now by RSNA. But then also right now, if people are interested in giving board reviews and participating in research projects and being involved in journal clubs or other projects, that's always much needed. So, anyone who's interested should feel free to reach out to us. I can say is that every faculty, nurse, and technologist who's been to Tanzania and worked on this project has really, first of all, had a great time. And secondly, a lot of people have really described it as like a life-changing trip for them, because it's so rewarding and actually sort of helps put things into perspective. Because, over here, sometimes we get frustrated with the little things, complain about like room turnover or your paperwork. But then when you actually see that as an interventional radiologist, you can literally save people's lives on a daily basis, it's extremely rewarding. So yeah, many people have expressed that.
Wonderful, wonderful. Well, Well, thank you guys both so much. This is again Fabian from Yale, who's an interventional radiology fellow, heading off probably pretty soon to become a faculty himself, and then Frank Minja, who's now at Emory University as a faculty in neuroradiology, who have created Road to IR, the developers and founders of it. So glad, and thank you for chatting with us today. It was a pleasure.
Thank you so much.
Thank you so
really
much.
Appreciate the opportunity.
Dr. Bhavya Rehani is an assistant professor in neuroradiology at University of California, San Francisco. She trained at Massachusetts General Hospital, Harvard Medical School. Dr. Rehani has been involved in multiple projects addressing health inequities for over 10 years. She's passionate about the application of technological innovation in finding sustainable solutions for global health. Dr. Rehani founded the nonprofit organization Health for the World in 2016. Goals of Health for the World include to leverage technology to increase access to healthcare for patients, as well as to improve medical education for students and residents, especially in low-income countries. To reach these goals, Dr. Rehani leads a large, diverse team of healthcare professionals and others. Her achievements have been recognized with numerous awards, including being named as one of the Rising Stars 66 Leaders in Healthcare Under 40, Female Innovator of the Year, Tech Startup of the Year, and many others, and her work has been funded by the RSNA Education Scholar Grant, among others. Dr. Rehani also serves as a mentor to some of the most talented medical students and radiology trainees. She's also giving the RSNA annual oration this year, as I just learned. Truly inspiring. Dr. Rehani, thank you for joining me today.
Thank you so much, Hannah, for having me. This is a pleasure.
Please tell us more about what initially motivated you to start Health for the World.
Yes, so this was inspired by my grandfather. So my grandfather lived in a small village in India, and he did not have access to basic health services. So he was a nice man, and who lived in a small house in the village, and all the villagers knew him. He used to ride a bike and check on everybody's well-being and make everyone smile. But unfortunately, he had a stroke. And when he had a stroke, I was at high school at that time, and there were no doctors, no physical therapists, no speech therapists to help him. So he suffered not just hemiplegia, but also aphasia. So he lost his voice. So I just saw the problems which, could rise because of lack of health access. And it made me wonder, why is there so much of inequity in healthcare? That people in the larger cities can get very good healthcare, especially if they can afford it. But if they decide to live in a small village and have a small community of their own, they have no healthcare. So just going through the personal experience, and he was a sport about it. He tried to just be very optimistic through the course of this disease. But it made me think of how we can solve this problem. So I think the seed was sown at that time because I just hoped that nobody else goes through the suffering which he did. So then I went to medical school, residency, fellowship, and then throughout I was thinking, we need to give back. We need to help people who do not have access to healthcare resources. But I think the time was so busy during training that I did not have time to set, something up. I used to volunteer at health camps, and it was very inspiring. But the problem was sustainability, because you start something and you do something, you visit a place, you work there for a month, you come back and your impact is gone. So the question was, how do we set up something which helps long-term rather than short-term? Right. So before moving to UCSF, I took a world trip, went to different countries, visited villages, and just got some feedback and ideas about what can help. And after moving to San Francisco as a faculty, I took some time to start Health for the World. So that was the inspiration behind Health for the World.
That's really amazing. And so what would you say are the main global health challenges in oncologic imaging today?
Yes. So I think there are three main challenges in global health in oncological imaging. Number one is education. So we did worldwide surveys to understand what are the needs in general radiology. And the feedback which we got was that there was a huge need for subspecialty training. And most of the radiologists around the world just get general radiology training. For example, the continent of Africa only has 15% of subspecialty training in the entire continent. When we did the survey, neuroradiology wasn't there in the whole continent. Many people expressed the need for oncological imaging training. So the need for education was really big. And that's why we set up the Academy website to provide free of cost education. The main challenge is there are really good online sources available. But if they are paid, people in developing countries cannot afford that. And the ones which are free on YouTube may not be reliable. So the question is, how do they access top-notch, reliable online access to oncological imaging resources so that they can learn and also mentorship? So the first is education. Second is access to imaging. So about World Health Organization estimates that 50% of the world has no radiology. So the problem is CT scan access, MRI access for oncology imaging. So that is the second. The third is research mentorship, because many people are really doing very exciting work in oncological imaging, but they are looking for mentors to do that research. So, and unfortunately, they cannot find mentors in their own country. So the research mentorship is the third challenge, which we have noticed during our work in these countries.
Really interesting. And I would love to hear about some specific projects centered on oncologic imaging and therapy that Health for the World is currently developing or that are underway to address these challenges.
Yes, absolutely. So we have addressed oncology in a more multidisciplinary fashion. So one is oncological imaging, second is clinical oncology, and third is palliative care. So we were very blessed and lucky because when we started, two of the co-founders, me and Dr. Bill Dillon, who's the Executive Vice Chair of Radiology, and who's excellent, both of us are radiologists, and our third co-founder, Dr. Minja, is palliative care. And we really understood the importance of multidisciplinary care. So, so as far as education, we were very lucky to have leading professors from close to 22 academic institutions who volunteer to teach in multiple aspects of oncological imaging. I can name a few. We have Dr. Judy Yee, who's the chair of radiology at Albert Einstein, who talked about imaging workup of focal liver lesions. She is excellent. We have a talk by Dr. Jim Brink on pathways for the spread of disease in the abdomen. Then imaging of bone tumors from Dr. Smitterman. From CST, brain tumors from Northwestern, Dr. Virginia Hill, and pancreatic cancer by Dr. Dushyant Sahni, who's the chair of radiology at University of Washington. We have so we were really lucky, and then multiple really good breast imaging talks by Dr. Rita Freemanis from UCSF, and Dr. Heather Greenwood, and Dr. Tatiana Kellel. And then one of the very interesting topics is HIV-associated malignancies, especially in the low middle income countries, which has been given by NIH. So, so those provide really extensive online education, and this is all free of cost. And there's also a YouTube channel for this for imaging aspect. And then the clinical aspect of oncology has been again given by multiple professors. So from Stanford and other institutions. So we have education in colon cancer, breast cancer, brain tumors, and then finally palliative care. There's a whole palliative care curriculum for end-of-life care or for oncological patients. So all of this is on the academy. As far as research mentorship, it has been a very important part of what we do. So we mentor faculty, residents, and students, so we connect them with mentors within US and Europe for exciting projects in oncological imaging.
That's really great. It's great that you mentioned mentoring, since that's what's going to be my next question. Mentoring radiology-bound medical students is an important aspect of your work. In fact, not only radiology-bound. Interestingly, I recently learned that 3 of my own mentees that I work with all work with you in some capacity. So I have to give a shout out to Aditi Charazia and Jose Rodriguez and Jefferson Gwen. They're all fantastic, and they're all involved in various projects with me, and they all speak extremely highly of you. So I'm sure there are more medical students and trainees out there listening, maybe getting inspired to get involved. So how can medical students and radiology residents and fellows get involved in Health for the World?
Yes, and first of all, thank you for what you do. It's very inspiring, and I've also heard really good things about your mentorship and your work, and I also follow you on Twitter. So thanks for all you do, so I have a lot of appreciation for that. And yes, as far as the mentorship, so Aditi, Jose, and Jeffers, a big shout out to them. They're just excellent. And we have been very blessed because we work in 80 countries and we meet the greatest people around the world. So the way the medical students and residents can get involved is, number one, they can reach out to us directly. So if they reach out to us directly, we can connect them with a mentor. And I myself am involved in that process. So I also do the mentoring myself. And if it is a specific subspecialty, I connect them with the mentors in that specialty. So they can volunteer with us and get mentorship. Or if they have other dreams and aspirations, we also try to do that. So for example, if they always want to do a research project, but they did not have the resources, so we help out with that. I'm also very passionate about international medical graduate because I myself am an international medical graduate. So and the journey is hard. So I really want to make it easier. I'm sure you do too, for people who follow us. Number 2 is starting a chapter. So we have had multiple resident and medical student-driven chapters. So for example, Aditi, she leads a chapter in India at AIIMS Bhopal. She's the president of the chapter. And it's very exciting because then they can lead the chapter. So then it becomes like a team effort. And they educate us about the challenges, where they are. And, we try to help out with the solutions. So that's a second way to get involved. But we accept with open arms whoever wants to work with us. This is a completely volunteer-driven movement. And they can just reach out to us,
Yeah, we will have all the information on our podcast website so people will be able to contact you. And I hope you will be inundated with requests.
Perfect. Thank you so much. Yeah.
Thank you so much for taking the time to speak to me. I look forward to continuing to follow you and your inspiring work.
Same here. I'll continue to keep following you and your inspiring work. And thank you for all you do. Thank you.
This concludes part 1 of our Global Health themed podcast episode, and I look forward to sharing part 2 with you all soon. You will find more information on all guests and our trainees who contributed to this episode on our website. Please subscribe to our podcast on Apple Podcasts or wherever you get your podcasts and give us a rating to help more people discover our show. I'm Dr. Jana Ivanidze, and this is Radiology, Imaging Cancer. See you very soon for part 2.